All right, so we'll get started. Thank you everyone for joining us for this webinar today. My name is Patrick Chiu. I'm the policy lead here at ARNBC. And today our webinar is around the topic of trauma-informed care. And there's been quite a bit of interest in this webinar. And I think it really shows that nurses and other care providers are recognizing the importance for integrating trauma-informed care into the practice. But we also know that many nurses and other healthcare providers just really haven't had the opportunity to familiarize themselves with the concepts, the impact, and the rationale for incorporating trauma-informed care practices, and that awareness among nurses and care providers could really enhance health outcomes and prevent re-traumatization. So this webinar has been developed in collaboration with the Association of Registered Psychiatric Nurses of BC, ARNBC, and it's part of a two-part series. The first webinar in this series will focus on theoretical foundations of trauma-informed care and will encourage dialogue among practitioners and their experiences. And the second one in the series will focus more on the strategies to integrate trauma-informed care into practice. I'd like to introduce our presenter, Tess Craker, who is the Vice President of the ARNBC and has been practicing as a registered psychiatric nurse since 1985, working in a variety of contexts, including the private sector and agencies such as Forensic Psychiatric Services, Correctional Service of Canada, and Vancouver Coastal Health Authority. Tess also works as a consultant for RPN regulatory matters and as subject matter expert for psychiatric nursing, competencies and practice requirements. Tess is very passionate about the subject of trauma-informed care and interested in creating dialogue with nursing colleagues to improve awareness and support of practical strategies to integrate trauma-informed care into practice. So we're going to hand it over to Tess to deliver the presentation, and we're going to save some time at the end for any questions. You are all muted right now, so if you would like to ask a question, please type it in that taskbar that's showing up on your screen, and sort of midway through that taskbar you'll see a little tab for questions, and we'll read it out loud at the end and address that when Tess is done delivering his presentation. So I'll hand it over to Tess.
All right, thank you so much everyone for attending the webinar. And first of all, I'd really like to thank and highlight Patrick on the incredible work that he's done on the presentation. He was key in developing the presentation and the content. Also want to highlight the fact that we've used a lot of existing resources and commend the work that people do in this field on trauma-informed care and practice. And so what we've done is we've just formulated a summary of some of the resources that are available. And on the PowerPoint presentation, we do list the references at the end, and so I would really encourage you to spend some time in those resources, learning a little bit more about where the information has come from, and it just shows the good work of people locally in BC as well as other provinces that are doing work with trauma-informed care. I also want to highlight the fact that I do not profess to be an expert on trauma-informed care. As Patrick mentioned, I am very passionate about it because through my employment experiences, I have worked with individuals that have been subjected to various types of trauma and see the enduring impact of trauma on their health status and their involvement in care. And so I'm not a professional in terms of being a subject matter expert on trauma-informed care, but because I work with the psychiatric population, I do see it a lot. And so what today is really about is creating some dialogue, sharing information and ideas, because it's these moments that we can take this information forward, even in our personal lives, but also in providing care for individuals to minimize the impact of trauma and re-traumatization for the people that we're supporting. So that's really what today is about. And again, we also mentioned that this is part one of a two-part series. So when we looked at the information, there was clearly information that we needed to be able to discuss that are sort of the theoretical foundations of trauma-informed care. But also, we wanted to give a dedicated time to talk about what actually the implementation of trauma-informed practices looks like. So we have dedicated a second webinar for that purpose, for the implementation into practice. And we don't have the dates established yet, but probably we're looking at around March. So what we'll do is we'll promote the second webinar once we have a date selected. So again, I really encourage you to ask questions, but I also really encourage you just to share some of your experiences on some of the subjects that we touch on in the presentation. So we'll get going. The first thing that we're going to be talking about is just identifying the different types of trauma, and then we're going to move on to articulating the importance of integrating it into practice, but just at a very high level. So on the slide, which is trauma is an emotional response or experience that overwhelms an individual's capacity to cope. What I would encourage you to do is, we're not always talking about patients. I really want you to cast your mind to some of the events that you've had in your own lives. I want to caution everyone on this is that it's not my intention to traumatize anyone here or to re-traumatize you. But I think in terms of understanding what trauma really is, it's important that we can relate our own experiences. Because when we're understanding the experience of the patient, it's important just to have a point of reference from events in our own lives that we have found to be traumatic, events that can trigger us as individuals, in order to be compassionate and to understand the experience of patients. So recently, I have, and this is just an example, is that I've been working at BGH, and there was one day in particular where I had the experience of working with individuals that one patient was a Somalian refugee who had actually survived a sniper attack. So she was significantly injured, but had survived that event. Another patient of mine was in a concentration camp in a war-torn area of the globe. And so these were just two examples of individuals that just through basic nursing care I encountered. And the stories that these individuals had were absolutely traumatic. So these are the types of people that we are encountering. And as we go through, we'll understand the impact of trauma. So what we're talking about now is the fact that trauma is pervasive in nature. It does not affect one specific age group, and it does impact people throughout the course of their life. So there are clearly more individuals that are vulnerable and maybe have more exposure to trauma than others. But one of the founding principles of trauma-informed care is that we cannot assume to know who has been through a traumatic event and who has not. We, first of all, have to approach care with individuals with sensitivity around trauma. And this begins to formulate our approaches with them. This begins to inform our questioning of them in a way of just being sensitive to the types of things that they've been through. When we are understanding trauma, so again, more of a theoretical foundation, we're talking about single incident trauma and repetitive trauma. So these are just sort of the definition pieces where a single incident trauma basically refers to a time-limited stressor that is characterized from a survivor's unpreparedness or a high-intensity event. So examples of this may include a car accident, experiencing a natural disaster, experiencing a sudden loss, or a single episode of abuse. So I actually discussed this with my students, and in a classroom setting, some of the students were sharing some of the single incident trauma that they had experienced in their lives. And there were several examples of car accidents, several examples of people just happening to be in a situation where they witnessed a serious assault or a violent act. And, these were clearly traumatic events for them. When we talk about repetitive trauma, we're talking about events that occur on more than one occasion. They may be a sequential stressor, but their effects are cumulative. So this could include an individual that's living in an abusive situation or a domestic violence situation, somebody that has come from an area of the world that is war-torn, and it usually occurs when somebody is trapped in a situation and they're not able to easily get out of the situation. So that category is a repetitive trauma. So some more definitions. We talk about historical trauma and intergenerational trauma. These are very important concepts to understand. Historical trauma is the cumulative emotional and psychological wounding that occurs over a lifespan. So you could have examples of people like we talked about that have lived in war-torn areas that are refugees, people that maybe live in a demographic of the country where the area is poor, and just because of the nature of some of those demographic circumstances, they're experiencing more exposure to trauma, to illness, to disease, to violence, to substance use issues, and things like that. With historical trauma, we talk about intergenerational trauma. So one of the most sort of examples that we experience locally is colonialism with residential schools. And so we have generations of individuals who have sustained the residential school system, who have experienced trauma, and some of those traumatic events and traumatic histories continue through the generations. So now we're moving on to complex trauma. Complex trauma refers to multiple chronic and prolonged adverse events. So specific examples of this may include neglect. So we're talking about potentially children early in life experiencing issues such as abandonment, witnessing violence within a family situation, having exposure to death and disease in their community. And one thing that I would encourage you to do is we talk about the downtown east side population. There are individuals whose life circumstances, so it may be trauma that will be a factor in them actually finding themselves in a situation where they're living downtown east side. But because of the demographic and the types of things that are occurring there, they're also more susceptible to experiencing ongoing trauma because they are living in an area where they are just vicariously more exposed to violence. Recently, we have the opiate overdose crisis, and so they're losing friends, and they're seeing people overdosing, seeing people resuscitated, and so there's an ongoing traumatic exposure to them. One of the studies, and this is the next slide, of adverse childhood experiences, was a study that was conducted. This was one of the largest studies conducted looking at childhood abuse and neglect and some of the long-term implications of exposure to these elements. The study was conducted and examined the relationship between childhood abuse and neglect, and then the healthcare and well-being, or the physical health presentation of people after exposure to these early experiences. So we talk about not only trauma affecting an individual psychologically, but there's also studies that now paint a very clear picture of the fact that exposure to trauma will have physical and physical impact on individuals. So in this study, they found that children who were exposed to trauma were more likely to experience adverse effects such as developing mental illness or mental disease, engaging in high-risk behaviors, enduring financial stress, and as a result of these factors, having less opportunity for education or for advanced education. Some of the physical health concerns that this demographic was found to endure included a greater incidence of acquiring cerebral vascular disease, cardiac disease, respiratory and hepatic dysfunction, as well as other chronic diseases. So this is the relationship between psychological stressors and trauma and poor health outcomes for individuals that are experiencing these things. The next slide is just a very kind of high-level detail of what is actually occurring when somebody is exposed to trauma. So I will read it through, and if you do have questions about the translation of some of these elements, then we can certainly talk about that later in the presentation. So what's happening is that when somebody is experiencing trauma, basically the individual's fight or flight system is activated. So the response is mediated by a portion within the brain, and over time what scientists have found is that with frequent exposure to trauma and stress, it actually starts to change the biology of an individual and their ability to regulate internal and external stimulus. So sometimes in situations, we do see this in psychiatry and other areas of care provision, is that individuals are not as adept at regulating their emotional responses. That may include them, being hypervigilant of the care that they're receiving when they are receiving care and instruction. They're not responding in a way that, or they're responding in a way that people don't know how to handle. So if individuals that are maybe defensive, for example, staff are trying to intervene and then end up having to be more assertive with their care and limit setting and things like that. But they're not really understanding the basis of why somebody may be resistant to care, or if they're not able to process the information or the instruction because they're actually being re-traumatized and triggering. So individuals that have had exposure to trauma and multiple traumas can actually have a deregulation or a deactivation because of their previous exposure, and psychological changes can become evident when we're trying to support. So as a review, and this slide is a really good example and a great resource, it just details what prolonged exposure actually looks like for people. So these are the types of behaviors that we're going to be seeing with individuals that may have had prolonged or frequent exposure to trauma. And so just really quickly, they may have an impaired ability to create new neurological connections or pathways. So what we would do is we would see them defaulting to a behavior or an emotional response. They're dysregulated in their response. They have a decreased cortisol and epinephrine levels, inhibiting future response to trauma. So what can happen is that they're actually not, their fight or flight system is not providing adequate support for them. So they may not be aware to avoid a situation, for example, that could be potentially dangerous memory, learning, personal coping, and emotional responses. So we start to see stressors with relationships, interpersonal relationships, inability to cope, more presentation of anxiety, types of behaviors. Physiologically, we will also see somebody having increased heart rates, abnormal adrenal activity, abnormal blood pressure, and a weakened immune system. So these are the long-term physiological effects of exposed trauma. Individuals also have an impaired adaptive response to emotional experiences. So again, they are not able to or have an impaired ability to actually respond and adapt to emotional experiences. This begins to affect individual self-esteem. So we start to see presentations of anxiety, and in order to deconstruct the source of that anxiety, it becomes very, very challenging. So we see anxiety as a symptom of a much larger problem. Individuals also have difficulty with thinking critically, being self-motivated, and this is where we start to see some of the mood disorders and some of the mood regulation issues with individuals. Individuals also have heightened emotional response, can be aggressively reactive in social situations or in care situations, and they have dysregulated, disassociative states. So they're not able to engage with healthcare practitioners. Recently, I was working with an individual, and it was a very, very, very challenging situation. This was an individual who grew up in an extremely poverty-stricken area. And again, I really want to try and avoid stereotypes, but these are just the facts of some of the individuals that we're supporting. So this individual was got a very, very poor environment, had some fetal-alcohol exposure, had a reported, documented history of being sexually assaulted and physically assaulted as a child. And so was in a care situation where they were brought in under the Mental Health Act and met the criteria for certification. And so what happened was the family had visited, and the family was very suspicious of healthcare provision. They didn't believe that the individual needed to be in care. And so just by the family's presence, even though they were advocating for the person, we were in a real dilemma, because what was happening was that care was being provided against the individual's will because they were certified. The family did not agree with the care being provided. So it was just seen as them and an us situation. The guiding principles were that this person continued to be a risk to themselves and to others. So they were actually acting out aggressively and physically. So they were destroying property. They were lashing out physically at staff. Staff were being hurt. And so this person, when we were trying to intervene, was just simply not capable of having dialogue. And so our events actually, unfortunately, led to sort of a re-traumatization. We needed to maintain safety for the environment, but what that actually led to was the patient not trusting staff. It became a situation where we had to physically restrain the person because they were injuring people, and they had to be sedated. And so it was just a very, very bad situation with all things considered. So when we look at situations like that, we begin to try and deconstruct and try and understand how trauma-informed care could influence interventions. And so they are the most subtle differences, but the differences that will potentially begin to repair some of the damage that's occurred with people that are exposed to trauma and re-traumatizing events. So an example would be that we would sit with the patient, we would talk about portions of their day, what their day would actually look like. We would talk about and translate as much as we possibly could what the team was saying, how the patient felt about what the team was saying, make sure that the patient understands what the doctor is saying, decide whether or not they agree, and really try and advocate for them to be as involved in the process as possible, just prior to them actually being in a situation where they don't agree, they're dysregulated, they're reactive, and then interventions have to occur. So it's more of a prevention approach rather than waiting for an event to happen, because we do know that this person could potentially be affected and may not be able to receive information in a way that is going to help them to understand what's about to happen. So that's just one example of where all of this starts to come together when we're dealing with and supporting individuals that have challenges around dysregulation, history of aggressive outbursts. So back to sort of the overarching definition components. What we're trying to do by having a dialogue about trauma-informed care is that we're just trying to understand and have a conversation about how it impacts individuals who are seeking care. And so trauma refers to the ability to have this understanding and its importance about how patients may have experienced some form of trauma throughout their lives, and that the trauma may occur through the lifespan and does not discriminate against any one group. As we talked about in the second webinar, we are going to focus a little bit more on actually integrating practical strategies into our care. But also I think that anyone who, even if you're not a healthcare practitioner per se, if you are around individuals who you are supporting who have experienced trauma, we really want to be able to offer practical strategies so that you can integrate that into your interactions with individuals. But just as a really quick review, what we're talking about is trauma awareness. So in order to provide trauma-informed care, you first have to be aware that individuals may have had trauma. So we understand that it can impact an individual's development. People who have exposed to trauma cope with it in different ways. So there's really no one right or wrong way that individuals cope with trauma. And again, I encourage you to think about your own experiences. How do you deal with traumatic events that have occurred in your life? Do you avoid thinking about them when you have reminders of the trauma that you've experienced? What's happening to you physically? How do you cope with those types of things? So these are the types of things that we want to understand with the patients or the individuals that we support. But what we don't want to do is, trauma-informed care is not about understanding and dialoguing about the trauma that individuals have had in their lives. By doing so, we risk re-traumatizing people. So it is important to understand historically the events that people may have had in their lives, but trauma-informed practice is about an awareness and an approach to individuals. It's not always about the conversation. So when we're actually developing the relationship, we are just being aware of things that can make the biggest difference in individuals' lives and not necessarily knowing their background. So before we touch a patient, for example, we are going to ask for their permission to touch them. explaining a procedure with a patient, what it can do is it can alleviate stress they may be experiencing. It can alleviate past negative experiences that they may have had when they're interacting with the healthcare system or people in positions of authority or power. So just by having a conversation, we can mitigate some of those previous negative experiences. But we're also identifying environments for people and promoting community and an experience of safety. So we are understanding the types of supports that individuals need, and then what we can do is we can refer them or engage them or inform them of agencies and support services that are available to them in their local communities. We're also creating an opportunity for choice. So trauma-informed care is about advocating for the patient, having them at the center of their care, and creating the opportunity for choice, collaboration, and connection with their own care. By offering choice, we are promoting an individual's level of engagement based on their own safety and security needs. We are activating their support system, whether that be their family, their significant relationships, or individuals that they've positively engaged with through previous experiences. And we're also able to assess and monitor whether there may be just some simple information deficits related to the people that are trying to support the patients. So what we can do is we can use trauma-informed care practices and principles to actually educate people who are supporting the clients that we're serving. Okay, so it is important, and this is very high level, but I'm sure that these points will resonate. So why do we do trauma-informed care? Because it enables individuals to feel safe. It allows people to be supported and creates a better opportunity and a situation for them to actually for them being able to discuss their personal histories of trauma when they're ready. And it also allows people to seek help and to be more engaged in care when they have a better understanding of the reasons that they're in care and the strategies that are being proposed to assist them. So again, on this slide, at the very bottom, it's highlighted, and this is one of the most important takeaways from the presentation, is that disclosure of trauma is not necessary to be trauma-informed or to provide trauma-informed care. Through the work that we provide as healthcare practitioners, but also individuals that we support in the community, it's important to recognize groups of people that are a little bit more vulnerable in terms of the potential exposure to trauma. That includes Indigenous peoples, the LGBTQ community and individuals, refugees, the homeless, mental health and individuals that have experienced substance use issues, and individuals that have experienced chronic pain. So with Indigenous people, one of the key pieces is that there are the fact of intergenerational trauma that we spoke of a little bit earlier, which could include the legacy of residential schools, a higher propensity for abuse, racism and discrimination. With the LGBTQ community, the facts are that these individuals have a bit of a higher rate of substance use issues and have also experienced discrimination, social isolation, violence, abuse, and bullying. With refugees, many have escaped war-zone countries and conditions where they've endured physical and mental trauma, persecution, imprisonment, or torture. With the mental health and addictions population, these individuals have had trauma or are experiencing trauma on almost a daily basis. With chronic pain, individuals have experienced trauma on a daily basis as well. One of the facts was that 51% of homeless people in a study that was conducted in British Columbia found that of the homeless population, 55% reported physical abuse, 60% reported neglect, 58% reported emotional abuse, and 57% met the criteria for PTSD. So this resource is available, and the study is available to you in our list of references. So we talk about just ways of engaging in trauma-informed care, and these are the beginnings of the practical strategies, and these are the types of elements that will be discussed in further detail in the second webinar. But on a very high level, we're engaging in trauma-informed care by being open and honest about our communication in order to reduce stigma. So when, for example, we're talking with people who have substance use issues, we're not going to be talking about addiction. We're going to be using language that we recognize people use substances for a variety of reasons, and we speak of it very matter-of-factly, and we do it in a non-judgmental way. Trauma-informed care also translates to us acknowledging people and being aware of our own personal biases and triggers. So the reality of healthcare is that we have had our own experiences. We have had individuals maybe who are healthcare providers that have come from domestic abusive situations. And so when we're supporting individuals who may have had similar traumas, we have to be aware of our own triggers. So we don't want to be trying to assist somebody where we're being triggered ourselves or we're being judgmental. If we've had negative experiences with somebody who's had substance use challenges, for example, and we've had our own, family experiences with that, we have to check in to make sure that we can provide care to people in a non-biased and open-minded manner. Trauma-informed care also includes us understanding that trauma survivors and their mechanisms of coping have been altered. And so we have to be empathetic about their responses and some of the behaviors that we'll be seeing. In one of the later slides, and it's one of the most, one of the best examples of switching our mind to trauma-informed practice, and that's rather than looking at somebody's behavior and saying, what is wrong with you, we change our mindset and our approach to ask ourselves, what has happened to you? Because with behavior, there's usually a reason, and so it's understanding the reasons of behavior rather than just focusing on the behavior itself. We also, again, want to be aware of just the language that we use to describe people that we serve. We want to continue to support and advocate and reduce stigma when it comes to individuals that have experienced trauma and the various ways that they cope. We want to be compassionate and strength-focused in our interactions. And we want to work together to identify how trauma-informed care can be enhanced in healthcare. And so that's part of what we're doing today, is that we're just creating dialogue. We want to provide basic information that you can take forward to use in your daily interactions and your care to continue the dialogue about trauma-informed practice so that we can, and again, even if we avoid re-traumatizing somebody once because of some of the things that we've learned today, then it's all been worth it. I'm just going to flip over that last slide, and just as I mentioned, this is the mantra for trauma-informed care. What is wrong with you is the question that we see when we're trying to understand behaviors. And we want to change that to what has happened to you. So that basically concludes the presentation. I know that it was a lot of information. Again, I really encourage you to spend some time in the resources. I guess the biggest takeaway from today is that I would encourage all of you just to have ongoing discussion. Again, I say that I do not profess to be an expert. My goal and my passion is to talk about the concepts, to create dialogue amongst healthcare professionals and individuals who are supporting individuals in other capacities, to change the ways that we approach individuals, to look at ways of understanding behavior, reserving our judgment until we actually do formulate opinions on behavior, you know, and recognizing the fact that we all come from histories that are unique as all of us, and you know, and it's with those kind of tokens that we want to just create a better environment for people who have experienced trauma. So we're just going to go to some of the questions. Patrick, do you want to just read out the questions?
And just a reminder for those people who might have joined us later on, if you would like to ask a question, just please type it into that taskbar that's located on your screen. Double-click on that question tab, and we'll read it out loud. So the first question is, could the impacts associated with prolonged exposure to trauma also be seen with someone who had single incident trauma or a few incidents a long time ago but never healed from it? Or is this only if trauma is ongoing?
I would say that, well, one thing that I've found is that sometimes you would have a significant traumatic event. What can happen is there's a re-triggering of that event. So, say for example, somebody, I'll just try and think of an example. Very, very simple example. Somebody was at work, they got involved in a rumor mill. People were talking about them to the point where it actually led to somebody losing a job. What could happen is that all of the elements that represent the job, for example, could serve to be reminders for the individual and create a situation where they're being re-traumatized. So say they're out of work. They have financial pressures. They have had a change in their employment, social network. You know, they drive past a bank. They're reminded of the financial stresses that they're dealing with. They start getting calls from debt collectors. They have rent due. They had to have a conversation with their parents or their support system about how to make their month's rent. You know, these are all examples of one single event, but ongoing exposure to reminders that can actually trigger and traumatize somebody. So when you start to see the long-term effects of trauma and re-traumatization, it basically ends up in the same place where if you have somebody who has multiple exposures, this is where you start to see the physiological taxing of the system. This is where you start to see the fact that they're becoming dysregulated. They're developing anxiety. They're developing depression, potentially as a result. So I would think that the long-term effects of a single versus multiple traumatic events could potentially be the same. But with the big difference of the fact that the single point event, that event is over, and now you're just dealing with the symptoms and the you know, the triggering components, versus a situation where the the same source of trauma is occurring over and over and over again. I think that if you have somebody that's involved in a situation where they are not able to get out of the situation, be it a domestic violence situation or maybe being a refugee and having multiple exposure to traumas, I think that there is a difference because somebody is really not going to have the ability to step outside and that resolve some of those issues. But I think that if an individual is not getting help, then it doesn't matter if you've had a single point re-traumatized with triggers or multiple traumas. If you're not getting help and you're not working through resolving some of these things and being outside the situation, then you're going to start to see the long-term effects.
Great. Just a few questions around when Part 2 is available and will the slides be available for sharing. So Part 2, we're aiming for sometime in March, so keep an eye open for that. The slides will be posted and as well as a recording of the webinar probably by the end of this week, so check back on our website for that. It'll be posted both on the ARNBC and ARPNBC website. One question, as healthcare providers, is there a duty to report children being exposed to trauma or abuse via their family? For example, if we notice signs of domestic abuse in the parents, but no signs of abuse are noted in the children.
Yes, as healthcare practitioners, there is a duty to report. That is probably best handled through the senior administrative group at your employer. Sometimes you can also elicit the support of your registering authority for some guidance around that. This is an interesting question, and I just want to highlight this because what it talks about is some of the challenging situations that we see in our local communities. One example is, and again, it's not a stereotype. It's just some of the realities of what this is a conversation about our realities. It's not stereotypical. It's based in fact. So the Southeast Asian community, for example, we do see situations where there are domestic violence symptoms, but because of some of the living circumstances of individuals, women, sometimes it's men, but women generally have a tendency to stay because they don't feel that they have a lot of options. And then there's potential for more serious risk violence if they actually come forward. So there's a local group in Surrey. It's called NEVER, and it's the Network for Ending Violence in Relationships. What they have done is they've created some tools where they educate first responders and healthcare practitioners, such as those working in Emerge, to identify some of the less obvious signs and symptoms of domestic assault. And they also have data on some of the more commonly vulnerable populations. What the group has also done is they've created a little bit more of a specialized way of providing support for individuals who want to reach out, can do so in a way that they're not actually having to call a women's shelter. There's other ways they can elicit support. They can actually plan for support with police assistance and some other strategies in order to get out of situations safely. So these are examples of professionals who understand the nature of certain communities and the demographic, some of the really specific risk issues that are associated with some of the populations and situations that individuals are experiencing, and then have actually created mechanisms to try and meet some of the
The next question is, how can first responders, such as crisis nurses, emergency staff, and paramedics, learn about trauma-informed care, not using strong and direct language that could later prevent someone from accessing health services? Understandably, first responders are time-limited, but are also the barrier between vulnerable population and access to care.
Okay, that is a very good question. I think that you highlight one of the pieces that is really important, and that is based on the nature of the roles that we provide in various healthcare services. Sometimes it is hard to avoid some of the issues that relate to trauma. We don't have maybe the time to review collateral information or review files. We don't necessarily have the time to develop therapeutic relationships with individuals, to learn about their histories and some of the triggers that they may experience. And so I think that if we approach it more from the point of view that in situations such as being a first responder in emergency, we have to assume that the people that we're supporting have had exposure to trauma. And so what that does is that just gives us the very beginnings of the principles to apply in terms of their care. So the examples that we talked about is that an individual like this, we would provide as much information to them about the care that they're receiving as possible. We would involve them in decision making rather than telling them what's going to happen. We would say, okay, this is what we're seeing. Here are some of the options that are available right now. This is the information from the doctor. This is what the doctor's recommending, and this is how we believe we should be proceeding based on what we're seeing. How do you feel about that? We would ask for their consent before we're touching them. Even if they're in a semi-conscious state, we would be advising them of the things that are occurring around them as a courtesy and a way to avoid some of those experiences with potential trauma. So it's a very, very good question. We still have our jobs to do. We still have care to be provided with individuals. And the example that I gave earlier, once a situation actually gets to the point where patients are damaging the unit, they have potential weapons, they're hurting staff, the situation needs to be controlled so that we avoid other patients being injured. We also are controlling the situation so that other patients aren't being traumatized for what they're actually witnessing. So we want it to resolve quickly and safely. And so sometimes it's as simple as that, is that we need to do what we have to do. But to the point before we're actually intervening, we want to engage the patients or the people that are accessing our care in a way that's gentle, that's informative, that is consensual, and that we're sharing information and we're talking about the interventions that we're providing for them. I hope that answers your question.
I think we have probably time for maybe one more. I know there's a lot more, which is great. So the next question is, a lot of women nowadays are traumatized with their surgical birth experience when they really wanted a natural one. How do we help them?
I think this is a complex one because I think one of the elements is that you said that they wanted a natural one, and for whatever reason they were not able to have a natural one. So this is an example of an intervention that was required because of a complication or because of risk to a natural delivery. So I think supporting individuals like this is that we would first want to help them understand and be reassured that this is no fault of their own, that when decisions are made around this type of intervention, the potential risks are weighed against the potential benefits. And so one of the first strategies would be, just to ensure that people have that understanding of how decisions are made in terms of why this is actually chosen, and that it's not a failing of them in any way. But also, I think just anyone who has actually been through surgery, it can be traumatic, and so it's understanding, what was their experience like, being aware that if they are thinking about having other children, that they maybe look toward, the propensity of this occurring again, so educating themselves, but also understanding, are there going to be some trauma and triggers related to going into the hospital, to having consultation with nurses, to the smell of alcohol and all of those things that could potentially traumatize people. When we talk about trauma-informed care, one of the criticisms is that, well, everybody's had trauma, and we talk so much about this and make a big deal of this, but what we're trying to do is we're trying to be aware of the unique experiences that individuals have had, and our number one job and responsibility is that we want to prevent us from being a mechanism where people are re-exposed to trauma. So it's the sensitivities around that. We still have our jobs to do. We still have conversations to have with the people that we support, the patients that we're providing care for. But it's just doing it in a little bit of a different way. So again, I hope that answers your questions. Again, I am not an expert. I do hope that this has been beneficial for you. What I'd really like to encourage you to do, and even if, because there's a lot of questions here that I think are really important, and again, I feel that so much more could come of this by having your questions sort of read out loud, and then the group having a dialogue. So maybe from this, what we could do is maybe we could even look at having, and these are just ideas, but maybe a day where we dedicate to just bringing people together face-to-face, or we even look at doing some type of video conferencing capabilities where we can actually have more dialogue, have people that have experienced and maybe have some answers for some of these strategies to share information. It's really about dialogue and conversation. So I'm very excited about this. Your questions were wonderful. I do hope that you do take away from this. And Patrick and I will do a little bit of a debrief, and maybe we'll see if we can do more around this. But until then, we look forward to seeing you again on the practical application of trauma-informed care to practice. So stay tuned for the dates on that second webinar.
Absolutely, and just to remember that we will be posting this on our website, so if you have colleagues who would like to watch it at a later date, please feel free to redirect them to our website. And as always, if you have any questions or concerns or any ideas for us at ARNBC or ARPNBC, please feel free to email me at pchiu@arnbc.ca, and I'll be glad to answer questions or also redirect you to the right person. So thanks again for joining us, and we are looking forward to having you join us for our next webinar. So take care, everyone.